So we're gonna go ahead and get started. I mean, I was already doing ILD in 45 minutes, and now we're gonna do it in 40 minutes. So this is gonna be just a general overview. Obviously, we won't be able to go in depth into any of the pathologies that we will talk about, but that will be like a general overview to kind of give you the sense of when you get to consult or maybe you get asked a question, how to think about it as a starting point. And as the year goes on, we have a dedicated curriculum, the high resolution CT scans, and looking at those findings and generating the differential that is ILD heavy, but it also includes other pulmonary pathologies. So what I'm hoping to cover today, maybe divide this into 3 parts. So the first part, we'll do a brief introduction and maybe focus a little bit on why IPF is at the center of those interstitial lung diseases. And the second part, we'll go over a standardized diagnostic approach. Like you get asked a question, does this person have ILD, or what kind of ILD they have, and how would you approach it stepwise to kind of get that answer. And if we have time, we will talk about treatments, and we'll just keep it very short and brief. You'll learn that more in clinic as you see patients in your clinic where in ILD and ILD. So starting with the introduction, you'll often hear that on Maroun presentation. Thank you. So people will be presenting either on pulmonary service or making more often it's a patient with a past medical history of interstitial lung disease, and depending on how tired and interested you are, you may want to stop and correct them. It's not really a disease, it's a group of diseases that it actually includes over 200 diseases. To make things more complicated, we don't give them names, we give them like letters. It feels like more of an alphabet soup, right? All of these are like true letters of actual diseases. So to make it, makes it even more complicated and more of a black box for people. But I promise it's not that complicated. And hopefully as you go through the fellowship, it will untangle and you become much more comfortable with the file. Just like with everything else, when there's so many, we can't memorize all of those. We have to like group them into different categories. And the way we get have done for this is there are some things that we can identify, like exposures, whether with medication, occupational, environmental, connective tissue disease, associated ILD, and we have those. Sarcoid. There are a few other zebras and odd ducks in here. And then you have your idiopathic disease once you roll down the other stuff. And at the top of this list, there's going to be idiopathic pulmonary fibrosis. Today, I'm going to talk a little bit about IPF. We may touch on hypersensitivity pneumonitis, part of the environmental exposure, and maybe an SID. And I think that will be plenty for an introduction. So why do we have to have IPF kind of at the center of this ideas? Why do we focus mostly on whether this is IPF or not before we move on to figuring out what this is?
It's a progressive disease that's you have to pick early, so we can plan the patient for lung transplant and also start fibrosis.
Yeah. So the main reason we cannot place IPF at the center of this disease group is because it has a terrible prognosis, right? When we see someone with IPF who still goes with median survival of 2 to 3 years, that we know that this is not the same for everybody. Disease progression is different in different people. You have the A type here that's just going to roll downhill at the speed of light no matter what you do, and those drive a lot of this low survival. With more screening CTs, we're realizing that there is a subgroup that's fully progressive. We didn't catch them before because we didn't do as many CT scans. There's these in the middle that lose about 200 ml of FVC a year. And actually, we think that a decent group, or a majority of them, will actually progress via these stars. You guys know what these stars are? Yeah, so these exacerbations, those are really bad for you. They're not like COPD exacerbations. An IPF patient has about 10% risk a year of having an IPF exacerbation. When they do, it's really bad. So they have a 50% chance of dying while they're in the hospital. And those who do leave the hospital are at higher chances of exacerbation, and their survival expectancy is about 3 to 6 months. So if you get an IPF exacerbation, this is really bad. So this is why early evaluation is important. And just to put a little bit into perspective, comparing it to other cancers, when IPF is not even cancer, it only comes, it's worse survival than all of these cancers, only second to like lung and pancreas, which often are like advanced stages. So it's really bad news. And to make it even worse, like the symptoms are often vague and not very clear. So people will have a cough and then will have and it's usually elderly people, and it's people who have smoked. So they get this having COPD or having heart failure or having something else. clubbing, that we always look at the fingers only present in about 15 to 20% of the cases. If you listen carefully on the scan without 3 layers in the jacket, you may hear oscillate, you may hear some bivasal soft crackles, but people don't do that as much anymore. And relying on a clear X-ray is misleading. It can be completely normal at about 10% of the people. To even make it worse, then they ask patients who are diagnosed with IVF, like when did you start having symptoms? When people tell you that you have, and more than half had a year at least between when they started having symptoms and when they were diagnosed. More than half were told they have bronchitis, asthma, COPD, emphysema, heart failure. So half of them went for a second opinion, and a third went for a third opinion before they actually got their answer. And the criticism for this article was, well, that's call bias, right? I mean, maybe they remember that, but they didn't tell anybody. Then what did we know? So they followed up with another one and says, like, no, let's look at their presentation to their doctor's office with actual shortness of breath. And this is the timeline from the time they were diagnosed, the patients who do have IVF compared to patients who do not have IVF. And we can see that they actually did present on multiple occasions to their primary care doctors complaining of shortness of breath. And it was really not very clever followed. So it is easy to miss. I mean, the follow-up point that comes up is like, okay, fine, we need to diagnose them earlier. Would that make a difference? And two, should I even bother to refer to a specialty clinic? I mean, there's really no good treatments. You're going to give them oxygen, you're going to make them hospice care, and eventually it's going to be the same. But that's not true. So on average, the delay between the diagnosis and referral to a ILD specialty clinic is about 2 years. And when they looked at how soon after the diagnosis we were referred and how that correlates with mortality, this black line, the Kaplan-Meier, is if you're referred within a year, you have about 70% chance of surviving to 5 years. If you're at 1 to 2 years, that drops at about 50%. If you're referred between 2 and 4 years, that drops to 30%. And if you're referred more than 4 years, which is being managed by your primary care doctor, it's less than 20%. Why that is, that wasn't obviously evaluated here. It's just a multidisciplinary approach and not just focus on therapy. There's managing comorbidities, there's protocol, there's rehab, there's early evaluation for transplantation. There's a lot of other things that the specialty clinic does that may seem simple to you, but it's often not done in a primary clinic, either general pulmonary. So what is IPF? So it's a progressive fibrosis. It's deadly. It's often missed, and when it's found, it's often not reported. But what defines IPF?
Clinical relapse of GPUs more of the case.
Okay.
And there shouldn't be enough likely to on GPU.
So the idiopathic is good. The rest I'm going to put on the side to over. What else?
So based on the yes, there's 2 statements. First one, the middle of the statement is to be negative exposure history, and second, negative autoimmune disease, and then typical CAT scan features.
Good. So we're gonna take a little detour from this. So what you said is the same as idiopathic, right? To rule out other possibilities, but it's like it's a progressive disease. It's going to progress in everybody. It is limited to the lungs, occurring primarily in older people. Now this is not always true, as we're learning about familial IPF and short telomere diseases. We realize it's not always limited to the lungs. There can be liver involvement, there can be bone marrow involvement. But the purpose of this for the most recent statement is it relies on an idiopathic UIP on histology. Right, so that is how IPF is defined. You don't always need a biopsy, but what you're going to try to do is what you're talking about is using the CT as a surrogate for this biopsy, so you don't have to biopsy everybody. But that UIP pattern is what defines IPF. And I like to talk about what that UIP pattern is. You get a biopsy people that send you a report. You want to make sure it makes sense what they're talking about. But before I do that, I want to just do a brief 1-minute review of the pathology of a normal one. Otherwise, the rest may not make sense. So if you were to biopsy just a normal one, what you should see is mostly going to be alveoli, and get enough distal to the parts of the lung. Should be within a centimeter of the floor. You're going to see alveoli there, right? They're going to have thin borders. They're not going to be very thick in here. This is where most of the interstitial is going to be. This is where interstitial lung disease is going to build up. You'll have bronchioles. Bronchioles are different than bronchi by the fact that they've lost their cartilages. So you would not see a lot of cartilages. If you do, then you need to biopsy early. It's not going to bifurcation and that cartilage. You should see bronchioles, and depending on how you cut them, they may look circular or they may look longitudinal. You recognize them by when you zoom in a little bit. on the slide with their ciliated epithelial stuff, and you'll have some vessels, you see some RBC. So if we were to zoom in on this, then it's going to be the same. This is the thin alveoli. These are the respiratory epithelium. You'll see the ciliated cells. Zooming in just even more on the actual alveoli themselves, the vast majority is going to be type 1 pneumocytes. And what do type 1 pneumocytes do? It's type 1 and type 2, so it's pretty simple. We don't have 6 different types. There are some cells of other cases. We're not going to talk about them. So what do they do? You get the second question. Yeah, so type 1 cells are just flat cells that sit out here. They contribute to passing a lot. So those are the respiratory parts that allow the communication between the epithelial cells from the vessels or next to them. And type 2 pneumocytes are the ones that make surfactant, but for the purpose of this, even more importantly, is they actually stimulate macrophages, and they can differentiate with the type 1 pneumocyte. They're heavily involved in the pathology of multiple diseases, including ILDs. So we'll talk about that in a little bit. But that's in general what things should look like at a low power field. So what defines your IP? How is your IP different than that normal pathology? What goes wrong? The pyroplastic foci is there. What else?
Area is normal one
Good.
histology, and then there's that goes.
Good. What else? So you touched on some of those things. So what we're looking for, this is different than it was before, right? So this is probably normal lungs, but everything else is into the symmetry. So what you mentioned is spatial heterogeneity. There's some areas that is actually normal next to areas that are actually abnormal. And there's temporal heterogeneity. The areas that are abnormal, some are early fibrotic, some are late fibrotic. And the final part of that is it can be so fibrotic part that it actually leads to architectural distortion, like this area or this area. These are honeycomb. They used to be normal ones. They got so distended, they became cystic in nature, and they look like honeycombs on the CT. So the key word is architecture, temporal and spatial heterogeneity, leading to architectural distortion and some type of plastic concept. And this is different than other ILDs. So this is spatial, temporal, architectural distortion. And these are the fibroblastic foci that you were mentioning. Any questions about this before we talk about how to get to whether they are IVF or not through the previous systematic approach? So this is like a typical example that you'll see often in clinic, like a 7-year-old person who have smoked 2 packs for 20 years, but a few years back has been short of breath for about a year, and he goes to see his PCP, who obviously thinks he's old, he smoked, he has COPD, they start him on an inhaler, they give them real for 2 months, that doesn't work, they come back, they give them triple therapy for another 2 months, it still doesn't work, and eventually, there's never PFTs done, the X-ray is not terrible, nobody really listens to their lungs, and eventually, when they don't improve their for pulmonary evaluation, this is the X-ray, like we said, it's not going to tell you very much. Like you can hallucinate a lot of stuff, but it's really going to look at a normal CT. So if you have someone that supports you and you suspect you've been listening to this morning talk, they have yeah. So what's the first step in your algorithm? So we're going to build this as we go. Good. I like that. That is a good place. That is always a good place to start. Here and on board, it's often going to be good. A good physical exam in history. What are we looking for specifically? So looking for potential causes. So looking for potential causes that could increase the chances of having an interstitial lung disease or IPF. What are these exposures that we're looking for causes?
Also, there's like. For example, birds, moths, the causes for HP, and others for like chemicals.
Good. So there are environmental exposures. There are drug tests, right? So what we're looking for is first is like drug exposure, because that's easy. You can look at their medication list and ask them what they've been on, and then we're going to talk a little bit about environmental exposure. That's one of the 2 potential causes that we usually look at. So getting a detailed history of medication is a good place to start. What are some of the most common medications of the mind when you're thinking about this? The license sounds good. Maroun is very good. Yeah, that's a med. true that is. So yeah, that is sure. So that's good to know. We'll talk about that when we talk about something in general. But sure, what else? I mean, it's a long list, right? So a lot of the newer therapies, a lot of inhibitors.
Yeah, same with newer biologics.
Yes. Yes. So my advice is for when you start, most medications can cause toxicity. These are just the ones we think about. But when do you guys go to check if they actually give these medications?
Newer laws.
Love it. You guys are way ahead of the game. So the best place to look is what they're thinking about. Let's see what comes up. It's actually a user-friendly website. They'll pop up the articles that they actually published it. This is where I'm has like 1,600 different publications. But that is true for a lot of other. So if you're wondering about it, just plug it into the box. It's good out nice for you and see if it makes sense. Makes sense or not. Now the next part of this is exposures, right? And those exposures are home, work, or other places. So a lot of the times we ask about work exposures, but there can be home exposures, or there can be hobby exposures, but we spend a lot of time doing other things. And when we divide those exposures, we usually divide them into inorganic stuff. And these are the chemicals that they're not alive, they're not harmful to us or other things that are alive. And these are divided into but the most common that we think about is silica, asbestos, beryllium, coal. And we will talk more about those when we talk about exposures and each one of those diseases. We have some toxic fuels in. But I do want to talk a little bit more about in today's presentation is those organic gases, which we were talking about, and if they feed birds, if they have air conditioning, if they do all that sort of stuff. So we're looking at hypersensitivity, right? Another name for hypersensitivity is extrinsic allergic alveolitis, which no one likes to use because it's mouthful, but it actually explains it well, right? So it is an extrinsic, so something is going to come in to the inside that's different than IPF already, right? So this is natural exposure. And a normal host, you're just going to be in the toxic. So you're going to ignore it, things are going to go. If you already have the genetic background for it, you're going to develop that alveolitis, is going to start inflammation at the level of the alveoli. It's going to start to spill into the interstitial, but in pretty bronchosvascular distribution. So the inflammation is going to be mostly around the airway. This is an inhalation injury. That starts to lead to those granulomatous inflammation. So this is the type, what type of inflammation? This hypersensitivity pneumonitis.
Sorry.
What type of allergic reaction?
Oh, type of
Yeah. Correct. So this is going to be a type 4. It's not like going to be any of the full type. It's going to be a specific type. It's type 3 and 4. So eventually it's going to be the fibrosis, but it's going to be mostly dominant around the airways in comparison to the subpleural parts that we see with IPF. So this is mostly type 3 and 4 reaction. And this is what it looks like on pathology compared to the rest. Like if you find an airway, you're going to find this inflammation mostly centered around airways rather than in there. So when we describe those in pathology, what you're looking for in the report, if you're not able to see the images, a little, this is going to be the epithelial cells. This is going to be most of the inflammation that's scarring around it. There's poorly formed granulomas that we mentioned here. So what we're looking at is ventricular fibrosis, relatively sparse in pleura and distal parts. There is very bronchovascular or very bronchometaplasia, like this is around the bronchi, so we're going to have that change in the normal cells that are in there. These are the granulomatous giant cells, and they're usually poorly formed granulomas, different than the sarcoid. Nicely formed granulomas. So this is kind of how the pathology is different than what we mentioned in IPF. The old classification, which I think is kind of useful, but has changed with time. We used to say, like, you get acute, subacute, and chronic HB, and acute is that you have heavy exposure, and then you have fevers, and you have the ground glass oscillation, and you have the subacute while you're being exposed on low intermittent, you develop that dry cough, and it's mostly nodules. And if you're exposed to really low doses, and with time, you'll just go to the ball fibrosis. And it's kind of like a mental scheme, but it's not true. Like no one presents with acute subacute or chronic. It's like a mixture of all of the above. So we get lower, higher doses on different days. So we moved from that classification to a newer classification that displays something that's even a newer one from last year, but not all that different. So now it's just that's fibrosis or inflammation, right? So you either have HB with fibrosis or you have HB with inflammation. The reason this matters is because we'll talk about what this matters in a second. So when we're trying to look for causes of HB, we're looking at a few different exposures, right? You mentioned, we have mentioned some of them already. So there's these work with mold and these are for the farming stuff. humidifiers or air conditioners, hot tubs. We have the birth and birth pain serum, the serum for those. We have prayer lungs. This is not good. I had a picture of what a weekly bowl looks like. But it's not very, it's too early in the morning. People haven't had breakfast. It's not. But in reality, the list of things that can do that is much longer. So the other one is just a simplified way of thinking about it. Now the question is, does it even matter? Like, if you look at when you do all the due diligence and do all the evaluations, you'll find an inciting agent less than 47% of the cases, right? So kind of like a half. So you ask them all the questions, you send your precipitate levels, you may even send people to their home to evaluate for mold, and you do all that stuff, and you'll come dry in about half. When you do find something, at least this is a U.S. population, so the most common was birds, eating birds, then mold at home were by far the two most common things. I mean, if there's farming practices, those are pretty obvious. They're like the mist, hot tubs, and the rest doesn't constitute like a handful. That's not the true wherever you go. And people from Indian descent, this is not the same distribution. Right? In India, they use instead of air conditioning in their cooler because they're more energy efficient, so they put water at the bottom, and it's just a fan, so it goes out cold air. These tend to grow mold because they're not cleaned as often, and this is the most common series of what they do, what causes HP in this population. So that can vary, but these are going to vary. There's 1, 2, 2, 1, or whatever distribution of the top view. That doesn't matter. Like you kind of have to ask them all those fateful questions of how do you spend your time? You enjoy hot tub time. You have to sit down and have a long 30-minute conversation about it. Like, is it worth it? Like, what's going to change if I find something? Or is it just an exercise in futility and building like a close relationship with your patients? Well, it does matter. So, one, picking it up early is important. So, if you find HP with no fibrosis, this is their expected survival. If you find it with fibrosis, you've already lost about a decade of survival. Right? So, if you catch them early, that's good. Now, if we find the inciting antigen, or if we don't find the cause, we also have gain about 10 years, right? So if you're able to identify what the cause is and remove it, their survival goes to about 20 years. If you don't, and they're just continuing to get exposed to it regularly, you've lost a decade of life, right? So it is worth finding that antigen. And the follow-up question is it worth it if they're at an advanced stage? Like, I mean, yeah, maybe it's worth it for install all inflammation, but is it worth it when they get to the point where it's actually all fibrotic? And the answer to that is yeah. So this is fibrosis or no fibrosis, identifiable agents or no identifiable agents. So if you don't have fibrosis yet, you're still improving. Even if you have fibrosis, I mean, obviously your overall survival is worse, but it is a lot worse if you're not able to identify that agent. So it's painful. Nobody enjoys those asking all those questions, but they are useful if we're able to identify it. Half of the time you do. And that is a useful thing for patients. The next one is the evaluation of connective tissue disease. That's what we talked a little bit about in the beginning. And this is a good history, and goes a long way, right? For their symptoms and evaluating their joints and their skin. And we do have a separate CPD ILD talk that we'll go over later in the year. But just as a general overview, I don't like sounding connective tissue disease. The more common that is going to cause ILD is RA. Like RA is in 1% of the population. About 10% of them would actually get ILD. UIP is going to be more common than an SIP pattern, but not by a whole lot. It's going to be like maybe 55, 45. Now, the one that gets most studied, most attention is scleroderma ILDs for all the trials coming from. It's not the biggest contributor to ILD in general, but about 90% of scleroderma patients are going to go on to develop ILD, but in fact, scleroderma is much less common than RA, so you still get more ILD cases from RA than scleroderma. And scleroderma, 80% of the time, this is going to be an SIP, and only 84 are going to be UIP pattern. Then you have your children that has an SIP, but also some odd types that we will talk about later, like lymphocytic interstitial pneumonia, follicular bronchiolitis, and other types of ILD. These are some basic serologies that we send. One of the ones that often gets missed is dermatomyositis and polymyositis. If they have muscle weakness, it's easy to identify, but there's a subset of patients that do not have myopathy that is not physical exam, and those are we call gathered, like clinically amyopathic dermatomyositis. They can still have ILD. This could be their initial presentation. It's usually rapidly progressive and pretty deadly. And you have to pick it up on serology. So we have what we call anti-synthetase syndrome, where it's sufficient to have like CT findings with serology even without the myopathy. And if you just send your regular panel as an anti-Jo1, which is going to be at the top of the anti-synthetase, but that's not the only one. Like PL7, PL12 are probably the two other most common ones that don't have muscle involvement and still have progressive ILD. Probably the deadliest of all, and we actually had a case of that a couple weeks back. Tony, that lady that we saw together in the hospital that's being evaluated for transplant left, and when she came to clinic, she had a positive anti-MDA5. If we didn't know that, we didn't send the extended lifespan panel, we wouldn't know that. And this is rapidly progressive, really highly deadly. People don't make it to 6 months. One of the common clinical things she did not have, but is these like ulcerating skin lesions. So if you see those and you see progressive ILD with it, those are often melanin derived antigens, and these are what causes skin lesions as well. So we've made it so far. Oh, we're gonna be lucky to make it to here. So what do you do next is you send a high resolution CT. And how is a high resolution CT scan different than a regular CT scan? This is a non-contrasted CT, right? That's gonna have some specific millimeter distribution of cuts. They're gonna be some overlap, and we're gonna use a parenchyma, sort of a special reconstruction algorithm. This is like what we call high spatial frequency algorithm, and then we get prone full inspiration, supine and full inspiration, and we do force expiratory films, then we do supine picture. And it's not really a high dose CT people worry about radiation, it's actually the low dose CT scan that is getting. It's not the ultra low dose that we use for like lung cancer screening, but it's still a lower dose than what you're getting for other scans. Prone pictures are useful for evaluating like these small changes, to be able to tell us if these changes are just static changes for the weight of the lungs because you're laying on your back. So if we flip you and have you do tummy time, and these clear up, those were just little changes, right? Now, on a different example, this is someone with scleroderma, they have these changes, you look at them on just a fine picture, and you really don't know this early scar tissue, or is this going to be just like static changes when they do prone, these persist, right? So these do not go away. So this is early fibrotic changes, you need to follow them sooner, and you need to consider treating them for their scleroderma ILD, because it's most likely going to. What's the point of expiratory films? What do expiratory films tell us? Yeah, so we're looking mostly for air trapping. What's going to happen? This is a full inspiratory film, right? So the way to tell the quality of the expiratory film, we look at the trachea, and you have to have some vagination of the posterior wall, and you're going to lose volume, and you can tell like this is going to get wider, right? So this is the air is black, it's going to have more density of the vasculature. It's going to look more hyperdense, but it's going to look homogeneously hyperdense. For instance, this is a different example. This is someone with transplant, and you're looking at them, and this looks fine. Like they're having a drop in their BFPs, but this is a full expiratory film, and it looks okay. Now you have them do an expiratory film, and they really can't exhale through all of this load and all of this load, right? These are the normal areas. Believe it or not, these are the normal areas of the lungs, and the darker areas that never increase in attenuation comparing to this one are the abnormal air trap. So they can be very useful. Air trapping in general is an inconsistent feature of IQ. So if you see that on a CT scan, unless they have a superimposed etiology of a small area disease or something else, it's not a common feature of when you get that CT, it's going to divide it into four different categories. It's going to fall, if you have a good radiologist, and if you don't, you may get a read that says CT consistent with ILD, which is not a good read because you ordered it for ILD. But if you have a chest radiologist actually looking at your CT scan, they should give you one of those four answers. Either going to come back as UIP, or come back as probable UIP. It's going to be an indeterminate for UIP or alternative diagnosis. And the reason we call them that is we're trying to get what the pathology is without having to pay the price of the biopsy, right? So the reason you're trying to find it based off of the CT scan is because we're trying to use that CT as a surrogate for that pathology, right? So what defines a UIP pattern?
So pleural involvement, local basal involvement level, presence of honeycomb.
Okay. Okay. So all good stuff. So it is what is going to fall on is the presence of honeycomb. So you're going to have all of the following ones that's probable and just indeterminate are going to have lower lobe predominance and subpleural articulation as a predominant. To be able to have a UI definite UIP pattern, you have to have some honeycombing, and it can have fraction conflicts of bronchiolitis. So if you're looking at it, you're seeing these reticulation by definition is what they're just in a regular white line. There's nothing fancy. It doesn't tell you anything about the etiology. The reticulation is in a regular white line. And as you're scrolling down, you start to see it's more in the lower lobes than the upper lobes. It doesn't mean that the upper lobes are normal, it's just more lower lobe predominant. It can be homogeneous, it can be unilateral. It's never upper lobe predominant, that will be inconsistent, but outside of that, it can be homogeneous. And you start to see these little cystic stuff at the base, and this is what we're going for, it's not, right? If you have that on CT, you have about 95, 97% chance of finding the biopsy. That's why the recommendation would never say go biopsy and put someone give them a 2 to 3% 30-day mortality to get an answer to 99% positive. So if they have this pattern and you don't have any other exposures or causes, you have an idiopathic UIP, you have IPF. Now that honeycombing story is not always easy. This is a small air-filled stuff. They have thicker borders than emphysema does. They're small. They can be up to 2.5 centimeters, but of course, mass majority is less than a centimeter. They're immediately subpleural. They can occur in clusters or layers. They share walls. They're non-branching, and they're usually associated with other scarring tissue, articulation, and other bronchitis. Now they're not always, and they're lower lobe. They're not always easy to tell. Like you guys say, this is honeycomb. What do you think this is?
Subpleural system.
Yeah, either not subpleural, not subpleural. What? Left. Yeah, so this is that this changes. There's subpleural. Lefts have to be bigger or a little bit more defined, but this is a subpleural. What is this? Is this honeycomb? So this is just bronchiectatic changes. So these are branching airways that you can tell there's even bronchitis down here. And you can tell that by looking at branching stuff. How about this? Yes, I like it. And how about this? Bizarre shape, cystic changes.
Cystic lung disease.
Good. So that's another. That's like ILDs. Cystic lung disease is also a chapter with multiple cystic lung diseases underneath. But this is BLCH. But we'll talk about that when we talk about cystic lung disease. And when they ask people to kind of like weigh in on this, they disagree with about a quarter of the cases. And if you attend our LDMPT, we will go on. Like, I don't know, it's too big, it's too small, it's too close to the periphery, it's not, it's in the upper, it's in the lower. So I can completely understand why a quarter of the time people would think it is or would not, and others would not agree. Probable is going to have the same as UIP pattern without it. So you take that equation out, now you have the subpleural predominant pattern, you have some fraction bronchiole like this is. Bronchioles are more closer to the periphery, so they don't have cartilages, so you have to pick them up closer than the center. This is the same, you're scrolling down, and if you start to look, this airway is dilated all the way to the periphery. It's not really dilated at the center. So this is the bronchiole, and it's actually being pulled apart by the scar tissue around it. So that's what the traction bronchiectasis or bronchiolitis come in. And if you zoom in a little bit more, that's what that looks like. If you have that, about 83% of the cases, it's going to come back as UIP on biopsy. So it's not going to deviate very much. 82 is not 100%, so that is worth a discussion with the patient. Most of us would not biopsy someone with probably, unless they jump up and down and say like, no, I'm going to know what 100% certainty and I'm going to take the risk. Then maybe, but outside of that, who convince most people of not getting the biopsy if you have a problem. And when you get to the determinant, that should be divided into two categories. One is like early UIP. If you think about it, it's the same. It's subpleural articulation. It is lower lobe predominant, but they don't have the fraction bronchiolitis. So this would look something like this. It's still those little lines in here, and they're at the base, but you don't have bronchiolitis and you don't have the honeycombing. This is the determinant. This is early UIP aspect. And there's the determinant, which is another subgroup. It's basically really indeterminate because you have some, maybe it looks like maybe honeycomb, but you also have ground glass, you have some cystic changes at the top, and you have maybe some nodular pattern, but really the kind of mixture of different things. Guess what? Even those still have about a 50% chance of being UIP on biopsy. Those we would recommend biopsy for And then you have that last category that actually says upper limb diagnosis. And this is where you really start to have things that so you have either cystic changes, so we're looking at the cystic lung diseases, LCA for conjugate and all the other stuff that we see. If you have really a lot of mosaic attenuation, like darker areas, wider areas, air trapping, and a significant amount of inconsistent feature, you have a nodular pattern, a lot of consolidation. These start to say, like, I don't think it's trapping, I think it's something else. There are some things to point at other specific etiologies like pleural involvement, geopathy, as you can see with connective tissue disease, dilated esophagus, scleroderma. If you start to pick up on some things that says like, that's not your IP, that's something else. Like this is one example of HP. That's what HP would look like. This is upper lobe predominant because mostly you're inhaling through upper lobes, right? You have areas of mosaic attenuation. Basically, there's areas that are darker and areas that are wider around them. This is air trapping. I think expiratory film, you exhale from all here, at least for left in here. You can look at this and say, like, this is just HP. I think this is not good IP. It's another diagnosis or this other diagnosis. To me, this looks like HP, and then that's where you land into this. Now, guess what? Biopsy is about 30% of the cases will come back as you have. It's just that IPF is the most common of those idiopathic pneumonias, and it ends up popping up on most of these. Given that the time is up, I think I'm going to pause. I'm going to pause here. What I'm going to say is, if you have your IP, then you have IPF. This is done. If you have probable and determinate or alternative diagnosis, we're going to talk about what to do maybe next time. If I advise you to talk again. Any questions? Yes.
So the UIP terminology can be used for both imaging as well as biopsy.
Correct. Correct. So the original came from the biopsy, right? Way before there was a PCR that can do the UIP pattern. I'm trying to correlate it to that. That's what we use that. So, correct. And it also will see that there will be a chart at the end that puts UIP on biopsy and UIP on CT and how to make sense of this one. But sometimes they won't match.
In terms of like catching these patients earlier, like you mentioned, a lot of the time they're not that straightforward, like just cellular shortness of breath, no measurements. They may have smoking history, they may have some other things. I mean, should we be getting CTs on more of these people? Should we be, I'm just trying to help sort out, when they come in with some other possible explanations for shortness of breath. And we don't get a CT on everybody, so what else should we look for?
Yeah, no, you're right. So having a high NS suspicion is going to be the element for this people who are the same category as COPD. So people in their 60s who have smoked for a while. Having PFDs may be helpful, right? Or pattern. A lot of the times we're wearing CT scans as part of screening. So you'll see some minimal changes on that CT even if it's not. Okay. What else? Anybody online has a question? Sounds good. We're going to stop here.